partially, right? Because it's trying to help, but it's not quite back to where we want it to be for 7.35 to 7.45. So this is a partial respiratory alkalosis. It is very common to get a partial or compensated. If you get uncompensated, how is that patient doing? Poor. They are not compensating at all. One point I wanted to say that I haven't said yet, kidneys take about a day to respond. So this person probably has been doing this for over 24 hours, or they've had this problem for 24 hours. So your respiratory component, your lungs, if they're trying to help, it's within seconds because we can breathe faster or slower based on the problem. Kidneys take a long time to react, so they're slower to get to the help. Okay? So this one may be a person that tells you that they've been doing it for a while. So let's think about respiratory alkalosis. It's partially compensated, and they have mild hypoxemia. What is the cause, do you suspect? We know at bare minimum, if I were to say on the test, and one of the answers was hyperventilation, you like that answer because they're hyperventilating right now. Hyperventilating just means you're breathing faster than the adult normal. Hyperventilation doesn't have to be like 50 a minute. It can be 22, 24, that is hyperventilation. Hypoventilation is less than 12, right? 12 to 20 is normal, less than 12 is hypoventilation. But if one of my answers on the test says hypoventilation is what is occurring, no, it's not. They're hyperventilating. You can tell that by the CO2 level. So there was two reasons, now there's probably more, but almost always the reason why this happens is because of tachypnea. They're breathing fast. So what causes someone to breathe fast? What's that? Anxiety. So that was one of the biggest ones. What's that? Ventilator. So let's talk about that for a second. So we'll start with our anxiety because we talked about that first. If someone is having an anxiety attack and they present with respiratory alkalosis, the first thing should always occur is therapeutic communication. That's going to be your answer on the test. You have to talk this person down. You have to use that calm approach, that, the close-ended questions. We don't want them to talk more. They're already having a lot of hard time breathing. Then, if you are not successful, is medication appropriate? Yes, the answer is yes. Always have in the back burner, if someone comes in with an anxiety attack and they're having chest pains, what do we have to do with that chest pain? We have to rule it out. We can't just say, you're not having a heart attack. That may not be the case. So they might do like an EKG just to confirm there's no heart attack, especially if they're having left-sided chest pain or palpitation. Okay? What kind of meds can we give for anxiety? So what are things that we could maybe give for them? Usually benzos are our choice. Probably going to give something IV. Why would oral probably not be appropriate here? It takes longer, and this is something acutely right now. This is not just like I'm having some anxieties off and on during the day. Like this is an acute emergency to the emergency department. They need something fast, or injection of some sort. Right? Now the ventilator. So we have settings on a ventilator where maybe they came in with a respiratory acidosis, where they were breathing slow, and we turned on the ventilator to have 20 breaths per minute. Let's just say that was the rate. But somehow they're also breathing 10 times per minute on their own. Now we have 30 for respirations for what they're breathing. If the ventilator caused it and our respirations are too high, what should we do if this comes back on our ABGs and they're on the ventilator? We should lower their respirations. Yep, that's what we should do. Would doing anything with the FiO2 help here? Would giving more oxygen help them breathe slower here? No, because what is happening is we're making them breathe faster, and that's still going to cause the problem. So we have to lower the respirations.
Okay, can you kind of repeat what you said? So if the CO2 is low, then you decrease, or why would you decrease the amount?
So this person is breathing fast, and we know that because the CO2 is getting expelled, right? So it's low. So if this person is in respiratory alkalosis because their respiratory rate is high, they're breathing really fast, we lower their respiration so the CO2 starts to become more retained. Because the slower you breathe, the more CO2 that comes back, this will start to come back up, and then guess what will happen? This will normalize. Yep. We don't need to do drastic. We don't need to go from 20 to 8, right? It might even be simple as 20 to 15 or 20 to 16, just to lower it a little bit. Because is this person probably severe? Not really. Okay, they're partially compensated, but their pH is pretty darn close to that normal again. So we don't need to make drastic changes, but some change has to be done. Okay? what could cause respiratory alkalosis on a ventilator that's not related to the rate? So it's not the actual vent settings, but there's some type of maybe pressure in there that's making them anxious and making them breathe faster. I'm hearing lots of things. Blockage, okay? So mucus inside of that tube, because if there's a blockage and your body's not getting the oxygen, the person's gonna like start to hyperventilate because they can't get their oxygen. Or there's a kink in the tubing, right? So if someone's like laying on it and there's a kink, that could cause respiratory alkalosis. So really, two things could cause it on the vent: blockage or a kink, or the settings are too high for respirations. Those are your two things for the vent. What are the treatments? Unblock it, right? Suction them out, get that mucus out of there. Unkink it if they're sitting on it, and lower the rate. That's what we should do. So this person had a rib fracture, okay? Now I want you to be careful with rib fractures can cause two different acid-base imbalances. So you have to see more in the question on the test if there's a rib fracture. Rib fractures could cause the person to be in a lot of pain, and they start to breathe really fast because it hurts, okay? That will result in this problem, which is what this person was happening. This person was breathing fast because they were in pain. That's what caused their respiratory alkalosis. What other problem could happen with a rib fracture from acid base? A respiratory acidosis. Now this is why. If they, for one, are getting too much of the pain medication, it's causing them to slow their breathing, or they don't want to take a breath because it hurts so bad. So if, say, they're having shallow breaths and they're trying to hold their breath because like they don't want to take these deep breaths, they might become acidotic because they're not getting rid of CO2. But if they're breathing fast and doing it pretty fast, they're going to blow off that CO2. So truthfully, you have to read the question. So I'm going to put in the question. Either got too much pain meds, or they're shallow, fast breathing. Okay, that's going to be more consistent with they're trying to breathe too fast. So just look for those hints. Okay. All right. Let's go to our other one. This was in the ICU as well. So you can see the trends here. So this was on March 21st, and look how many times ABGs were drawn in that first day. So they had it at 7 in the morning, 9 in the morning, 11 in the morning, 1 in the morning, 3 in the afternoon. Or, excuse me, 1 in the afternoon, 3 in the afternoon. So in the matter of 9 hours, 8 hours, they drew it 5 times. That's a lot. That's a lot of ABGs. But it should tell you what's going on a little bit. What are they probably doing with their treatments? They're changing a lot of things. So anytime a change is happening with oxygenation, maybe they're going from 6 liters to a non-rebreather, or they're going from a non-rebreather to a ventilator or a BiPAP. You have to check it again to see what. Did it work? Is this helping? And typically, when you have such a problem with this person, he or she, I'm not sure what the sex is very sick, you don't have 2 days to figure it out. You need to do it quick. So they are probably drastically increasing things fairly quickly. So let's start with when they first came in. So kind of going down that list. It's okay. Try to figure out the first one and see if there's any changes with the last one. So don't worry about the middle part, but go with the first. Did anything change with the last? Pay attention to what kind of oxygen they're on. Try to figure out the true PaO2. Okay, the true PaO2. A 15-liter oxy mask is about, the max they can get through there is about 80%. They cannot get to 100% on that because it's not as concentrated. Check out that black card. I think this person had an art line. I don't know this because I didn't look at it, but why do I suspect maybe they had an arterial line? Yeah, they had like 5, and I bet they have more. If we look today, I bet there's more. Actually, we should look at the middle of our time frame. I'll look and see if this person got better. We'll see what they did to get them better. I can log in and we'll see. They have to get these blood samples that many times in 8 hours. You know how much trauma would happen to your pulse if you did that 5 times? For the sake of causing more complications, they should put an arterial line in there and they can draw the samples every couple hours. I would be shocked if they didn't have an art line. That's just trauma to this patient that does not need to happen. So you're constantly putting a needle in someone's artery. You don't want to do that. It's a lot of trauma. Look at the second and third one. See how the PO2 was 90 and 88? What if a novice nurse goes, oh, it's pretty good. Why is it not pretty good? He's on 50%, I don't know if it's a he, but we're gonna say it's a he, is on 50% FiO2. How did I know that? The inspired O2 is the FiO2. So 50, okay, how much more, again, this is math, but 20 to 50, right? It's gonna be at least 2 times, 2.5 probably. So you take 90 and divide that by 2.5, you're probably in severe zone, right? So the person's on 50% oxygen and still in the 40s. That's not okay. This person's having problems. So what did we find based on the first one? Do we have an acidosis or an alkalosis? Acidosis. Is it high or low for CO2? Very high. This and all the people in this room should make you fall asleep. Nobody in this room, you guys don't have COPD. Everyone should be unconscious with this. I wonder if the person was. HCO3, bicarb is high. So do we have a respiratory or metabolic acidosis? We have a respiratory because the PCO2 is opposite of the pH. Your metabolic is not equal to your pH. Okay? Is our bicarb trying to help? Yes. And this should make sense why it's high. If it was low, we would have had a metabolic problem, right? Because it would have been equal. Base is trying to be increased because look how acidotic we are. It's trying to go back to that teeter-totter. Is it compensated? Like 100% compensated? No, it's partial because this is not back to 7.35 to 7.45. So we do have a partial respiratory acidosis. Based on 80% FiO2 with our oxymass, we're gonna say that's 80%. What is our true PaO2? Someone do 114 divided by 4. You wanna do that?
28.5.
20 what?
8.5.
Yeah, we'll say 29 for fun. This is where we're at, 29. Now does this make sense? You just retained all this carbon dioxide to the point where you're not breathing very fast. You're gonna die. If you don't fix this, you are going to die of hypoxemia. Because carbon dioxide in large amounts is enough to stop your breathing, enough to not get any oxygen to your body. So it probably makes sense that this person is that low. So again, the diagnosis for this person was respiratory failure, okay? But what could cause respiratory failure to this extreme? Let's think of some of our reasons for respiratory acidosis. Opioid overdose. Let's say they took morphine or they took oxycodone or lorazepam, whatever, okay? So some of those benzos or the opioids could cause it. I don't think that was the cause in this situation, but it could.
Acute chronic lung diseases.
Okay, lung diseases that would cause this, so think of COPD. It actually is pretty common, and I have a feeling this person has COPD because of this reason. I do believe this person, they're not on a vent. And the reason why they're on a BiPAP is because typically with COPD, they retain this carbon dioxide. They need some pressure to kind of push out the carbon dioxide, but they usually don't go on a vent. So maybe this person's baseline is in the 50s. I'm not saying that 85 isn't high, because it absolutely is. But they probably are tolerating it a lot better than we are, if that were to happen to us. Okay? So this person is actually on 29 for PaO2, which is very low. And so we probably are gonna think about some pretty extensive oxygen here. BiPAP is what they eventually put this person on. What is BiPAP? Bi means something. 2 pressures. There's an inspiratory pressure that goes in, and they call it PEEP. You guys ever heard of PEEP? P-E-E-P. It's the pressure that helps keep your alveoli open, so you can actually exchange the oxygen and carbon dioxide, and then there's a pressure to squeeze the alveoli to push it out. Because remember, COPD patients can't get their COPD or their carbon dioxide out, help push it out. Okay, so let's go to 7 hours later, or whatever, 10, whatever person's doing. Something changed with the FiO2, it's at 50%, but it's on a BiPAP. I will say that yes, it came up a little bit based on what this is. However, they probably still were working on this person. Maybe this person had a lot going on, and I would like to see what they are today. So we're gonna look at that in between, see how they're doing. Is the person still in respiratory acidosis? Yes? Has anything changed with compensation? No, it really hasn't. The numbers have changed a little bit. They're at 77 instead of 85. They even were up to 93 at one point, but I bet they were changing the settings quite a bit. One thing to point out is that the BiPAP probably will work in the time of 24 to 40 hours, but as long as the person is doing okay and not like stopping breathing, they probably will continue to do this therapy, but it can take time. Okay, so that was your respiratory acidosis example. Hey, I want to bring this up because I had this for a student. I'm just going to turn the light on now. So these two examples, anyone go to Two Green last night? I gave one of these to Brendan too. You might have saw this last night. But these two examples is how maybe you can look at it, because some of you are struggling with partial compensation and how to identify what is the difference. So if you look at the bottom, this tells you how to figure out, is it compensated, partial, or uncompensated? But I put one example of an acid-base imbalance and put it in 3 different ways so you can see across the board. So let's kind of start with the first one. I want you, just individually, go across for these 3 examples and figure out, is it a metabolic or respiratory acidosis or alkalosis? Don't do the compensation yet. Or you can, I guess, if you want, but we're going to talk about how we got there. So just do the top one and go across. Because the first one was on 80% FiO2. So when you get from 20 to 80, you can multiply by 4. Or, yeah, whatever the FiO2 is compared to the 20. So if it was 100, you would have divided by 5. I can talk about that again too. Maybe let's do a couple practice ones. Oh, they just set it up there.
So if they're on like 80% divide by 20, you add your KO2 divided by 4.
How do you do that?
So you take your
That was his SpO2.
percent
No, because that's not that FiO2. That's
Then how do you?
I took 114 and I divided by 4 because yours is like, an oxygen mask of 15 liters weighs 8%. You don't have to know for this test. I'm going to tell you an FiO2. So when you put a mask on someone, you never can get to 100% unless you go into something like lungs. So I just know that 15 liters is the max you can get for intubation, and that's 8%.
But you can tell us.
Yes, I'm going to tell you an FiO2. This is one question of your test. Please do not go home and spend an hour doing FiO2s. You will do yourself a huge disservice, okay? You really need to, when you're studying for this test, practice doing the problems. That's really the biggest thing. So 40% is just like, I'm gonna give some ABGs, you gotta tell me what it is. It is a black and white process, okay? There's gonna be drop downs that say like combinations of what you could have, but it's not gonna be, I'm gonna give you 4 choices and it's gonna be obvious where you can just guess. I'm gonna give you 4 that look very similar, where it might say mild, moderate, severe hypoxemia, but all the acid base is the same, right? So you have to really know how to do this, okay? You can't rely on chance, you just have to know how to do it. So the FiO2, although it is important to know how to get this, I'm pretty sure I just have one question that basically says, how do you get this, okay? So if you want, remember that 20% is what we breathe at room air, okay? Right now, no one's on oxygen. You are breathing 20% oxygen right now, 21, but yes, 20. The way we know how to get your PO2, your actual PO2, is to know how much oxygen they're on. So the SPO2 is that little thing with your finger. That is not FiO2. That is your oxygen saturation, how you're doing after, okay? It's not how much oxygen we're giving you. So I will actually put the word FiO2. That's how you're gonna know it's the difference, okay? So if I give someone 40% oxygen